Well, welcome, welcome everybody. Thanks for being here. This is the first of our annual updates on the work we've been doing through this program project grant that was awarded through the NINDS. Throughout the next period of time here, you're going to hear from many of the investigators who lead different areas. My name's David Limbrick, and I'm well fortunate to be one of the leaders of the project. Chen Yang Lu up here is a co-PI, and I want to acknowledge, of course, for those of you who don't know, Tanda Meehan, who is really runs it from a programmatic and operational standpoint. So really fortunate to have such great leaders and leadership. The rest of the projects are led by other individuals who you'll meet along the way tonight. So I thought actually in presenting today that I might start with some clinical cases. This is a little bit different approach than what I've done in the past, but I think will help to illustrate really what this project is all about. So if you have some disclosures. So the one thing I'd like to lead you with tonight is that all Chiaris are not the same. And so I'm going to show you a few examples. This is an 8-year-old who had daily occipital headaches. These are sort of classic Chiari headaches. Was treated with a posterior fossa decompression with duroplasty. I would say that's what most people with a Chiari malformation, if they have surgery, will want to go. And in this case, it was successful, and thankfully, this child, the headaches resolved. I did just take a look at the, see if this works here. Back here at the junction between the base of the skull and the top of the spine, just sort of get a sense or flavor for this. And then the cerebellar tonsillar ectopia, that's what people generally refer to as a Chiari malformation. So here's a different patient. This is a 5-year-old who has hypermobility. You'll hear more about that by then. You can see that this is a young child, and hypermobility and affects different people at different stages in different ways. But in this particular case, while there is tonsillar ectopia, meaning a Chiari malformation, it's relatively more mild, and there's fluid around it, as evidenced by the sprite signal here. So, fortunately, this patient has been managed non-operatively. So again, all Chiaris are not the same. This is a 40-year-old female, history of headaches and trigeminal neuralgia, which is a electric-like shock pain in the face. And in this particular case, you can see the Chiari malformation. It's projecting okay from back here. And a cervical serries, which is this fluid within the context of the spinal cord itself. Over time, the serries enlarged. And ultimately, this person underwent, again, the posterior fossa decompression with duroplasty. You can see the post-operative nature here. And fortunately, there was complete resolution at the syrinx. However, it's important to recognize that even though the syrinx resolved, they actually had a gradual return of pain. And this has been managed conservatively with physical therapy. And so this is an excellent radiological outcome, clinically a good outcome, but certainly aside that we don't know every little bit about what's causing pain and some of the other side effects that we see from this condition. So here's a 13-year-old with a history of EDS, which is another hypermobility syndrome. This is Ehlers-Danlos syndrome, and this patient sustained a concussion and was found to have this Chiari malformation. Mild ventriculomegaly. Now, this means that the ventricles were a little bit enlarged, and this was managed conservatively because it was detected, what we would say is incidentally, meaning only because they got a scan because of this concussion. Ultimately, though, the ventricles began to enlarge in size, and they were referred for neurosurgery, and an endoscopic third ventriculostomy was performed. So what's different about this one is that now we're starting to see some changes in the way that the cerebrospinal fluid is processed and flows. And over time, the hydrocephalus was treated appropriately, but because of the the genesis of symptoms around syringomyelia, for example, numbness and tingling in the extremities. They ultimately underwent posterior faucet decompression with duroplasty, and you could see the serines improved over time. So again, whereas we talked first about the Chiari malformation and then a little bit about hypermobility, and now we're talking a little bit about cerebrospinal fluid movement. Here's yet another variation. Now, this person presented at the age of 16 with scoliosis, so no headaches, no neurological symptoms, just scoliosis. And what's really interesting is you can see that the Chiari malformation and the syrinx is very large here. Now, we are aware that there's an association between syringomyelia in the setting of Chiari and scoliosis. But nevertheless, compare that syrinx size to what we looked at before. You can see it's very large. This patient underwent surgery, posterior faucet decompression again, and ultimately the syrinx nearly resolved, and their scoliosis actually corrected to a much more normal curve. And as Dr. Australia will hear from later, would tell you that it's very unusual at that age to have the scoliosis correct. So very good outcome for this patient. Here's one that's very different than what we've looked at. So this is a 9-year-old syndromic person. And what you can see is they have a history of multi-suture craniosynostosis. They have shunted hydrocephalus, and they have signs of brainstem dysfunction from this pressure along the front, or what we call the ventral brainstem. And when we look at the CT, which shows the bony anatomy quite well, you can see basilar invagination and some changes here in the craniovertebral junction. So this is a very different set of problems than what we've seen earlier in some of the other cases. Here's another one that I think is an exemplar case. This particular patient presented with headaches and neck and back pain, shoulder pain, and then developed over time extremity pain and hand grip weakness, so they were unable to even hold a brush or a phone. And they presented, they also had Chiari and syringomyelia. But there was something different about this one. So this one is markedly different for one important reason, and that is here. This distance, the mammalopontine distance, which is this distance right up here, is very foreshortened, and that is a good indicator of intracranial hypotension. So here it's a very different level. Maybe not so much a developmental Chiari per se, as it's related to perhaps intracranial hypotension, which can be seen in the setting of leakage of spinal fluid. Another finding that kind of tipped us off here is this perineal cyst. So sometimes in the spine, you can have dilations in the nerve root sleeves, which can leak fluid. So intracranial pressure was monitored, and it was largely -12, -10, so very, very negative. And that sort of confirmed this diagnosis of intracranial hypotension. And so a myelogram was done that demonstrated a fistula, which is a connection between the spinal fluid spaces and the venous system. So the fluid was just leaking out. And when it did that, it caused a negative pressure, and the cerebellar tonsils descended down and secondarily caused that serines. So this patient was treated with an obliteration of that fistula connection, and it improved. You can see actually here, it's a little bit difficult to see, but you can see up here that mammalopontine distance improved over time. But nevertheless, they continued to have weakness in the hands and underwent a posterior faucet decompression and duroplasty, and actually did very well. Was able to write and hold a brush and hold a phone. So really, the point to this, and I think the stage that I'd like to set here, is that there are lots of different kinds of Chiari malformation that can result from all sorts of different things. So I showed you an example of intracranial hypotension and CSF leak. We looked at an example of craniosynostosis. Pseudotumorous cerebri or idiopathic intracranial hypertension is another variation. And then hydrocephalus, tumor, trauma, other things can all be associated with Chiari malformation. So when we think about Chiari, when we talk about it, when you read about it, we always think about Chiari type 1 malformation for the most part, associated with lots of different things, lots of different symptoms. And in some cases, people have tried to put some guardrails around this condition to help us to understand it a little bit better. One example is the designation of Chiari 1.5, which plays on the example Chiari 1 and Chiari 2, so it's somewhere in the middle. And this is from brainstem herniation, not just cerebellar tonsillar herniation. Another example is Chiari 0 malformation, where there's actually no tonsillar herniation. On the other hand, there is syringomyelia. And even a Chiari 0.5. So these numbers and their relevance to the biology are really unclear, but they are useful in helping us to understand different variations, how these conditions can occur, and perhaps how they can be treated. But really what we're left with is a combination of factors and conditions that sort of are a little bit amorphous, right? And so what we're trying to do is really build a framework out of this amorphous material to help us to understand how better to treat this condition. So we can understand, can we choose a direction or a procedure or a treatment or a method that would be able to allow us to be more effective and more expeditious in the way we treat this condition.